Welcome to the Hospital Medicine Unplugged podcast. Today we're doing a deep dive, a really crucial one, looking at the differences between CPAP, continuous positive airway pressure, and BiPAP, bi-level positive airway pressure. We want to focus specifically on how these are used in acute and chronic situations in the hospital.
Exactly. The goal here is to really pull out the latest evidence, the framework you need right at the bedside for making those quick, sometimes high-stakes decisions.
Right. Which one do you choose? What settings do you start with? And critically, what are the safety protocols?
Absolutely. These are foundational tools for non-invasive ventilation, NIV. But, picking the wrong one or maybe waiting too long to switch to intubation, that can lead to really serious problems.
Yeah, we need to get beyond just knowing the names.
Right. It's about understanding the physiology. What problem are we actually trying to fix? And how does the machine, the mechanism, match that specific goal? That's what this deep dive is for giving you that evidence-based approach for fast decisions.
Okay, let's start unpacking that. Foundational definitions first. We see CPAP and BiPAP a lot for chronic obstructive sleep apnea, OSA, but their use in acute respiratory failure is, well, it's much more specific. Let's begin with CPAP. What's the basic mechanism there? Continuous positive airway pressure.
So CPAP is fundamentally the simpler of the two. It gives you just one single constant level of positive pressure. Typically, you start somewhere between, say, 4 and 20 centimeters of water. And that pressure stays the same all the way through inspiration and expiration.
Okay, constant pressure.
Constant pressure. And its main job, physiologically, is to act like a pneumatic splint.
A splint.
Yeah, think of it holding the airway open. That constant pressure stops the upper airway from collapsing, which is key in OSA, obviously. And then in the lower airways, it helps increase the functional residual capacity. Basically, it opens up more lung, improves oxygenation, helps with alveolar recruitment.
Okay, so it holds things open, improves oxygenation, but it doesn't actually help the patient breathe harder or take bigger breaths.
That's the critical point. It doesn't actively augment tidal volume. It makes the conditions better for gas exchange, yes, but it totally relies on the patient's own breathing drive and muscle power to actually move the air in and out.
I got it. CPAP, splinting, oxygenation, maximizing surface area.
Yeah.
So how does BiPAP, the bi-level positive airway pressure, bring in that idea of actually helping ventilation, helping clear CO2?
Right. BiPAP is specifically designed to assist ventilation. It gives you two different pressure levels.
Two levels, okay.
You get a higher pressure during inhalation, that's the IPAP, inspiratory positive airway pressure, and then a lower pressure during exhalation, the EPAP, expiratory positive airway pressure.
So the EPAP part is like CPAP.
Exactly. The EPAP does the same job as CPAP, splinting the airway, helping with oxygenation. But the key difference, the really important part, is the difference between the two pressures. That delta PIPAP minus EPAP, that pressure difference acts like pressure support. When the patient starts to take a breath, that higher IPAP actively pushes air into the lungs. So by making that pressure difference bigger, we increase the tidal volume. And that's what helps rest those tired respiratory muscles and really accelerate CO2 removal.
Okay, that's the core distinction then. CPAP is like a fixed splint, mostly for oxygenation. BiPAP actively helps ventilate, helps clear CO2. That seems central for acute care decisions. But before we jump into acute failure, let's just quickly touch on the non-acute side again. For straightforward OSA, obstructive sleep apnea, why is CPAP still the first choice?
Yeah, for just routine OSA, CPAP is still the gold standard. And that's because the evidence is really solid. You look at systematic reviews, meta-analyses, they consistently show that for uncomplicated OSA, where the issue is just the airway collapsing, there really aren't any clinically significant differences.
No difference in outcomes.
No significant difference in major outcomes, how well patients stick with it, or how much their symptoms improve, comparing CPAP versus BiPAP. Since the goal is just to split the airway open, and CPAP does that job well, it's recommended for routine care. It's simpler, easier to maintain, and importantly, more cost-effective. BiPAP just doesn't show superiority in that general OSA population.
Okay, the cost effectiveness makes sense. But we definitely see patients who are on BiPAP at home for their sleep apnea. If it's not more effective generally, why are they using it? Is it about tolerance?
That's exactly it. Comfort and tolerance become the deciding factor for some people. There's a subset of patients, especially those who need really high CPAP pressures, maybe above 15 centimeters of water. They find it really hard to breathe out against that constant high pressure.
It feels restrictive.
Yeah, it can feel restrictive. It can cause discomfort, maybe persistent dry mouth, or even aerophagia. That's where they swallow air, leading to bloating and discomfort. So BiPAP helps there because it drops the pressure during exhalation down to that lower EPAP level. That lower pressure makes it easier to breathe out, requires less muscle effort. And for some patients, that translates to much better comfort and, well, they actually use the machine.
So BiPAP gets reserved for those who just can't tolerate CPAP, even when it's properly adjusted, or maybe if they have other issues like hypoventilation.
Precisely. Either intolerance to high CPAP pressures or those with coexisting conditions like obesity hypoventilation syndrome, which we'll definitely get into later.
Okay, that clarifies the chronic stable picture. Let's pivot now to the acute setting in the hospital. This is where the choice can be, well, life critical. We have to start with the classic indication. Acute COPD exacerbation, but specifically when it's complicated by hypercapnia, high CO2.
Yes. This is really where BiPAP has its strongest evidence base. It's the go-to. If you have a patient coming in with a COPD flare and they're showing signs that they're tiring out, becoming acidotic, meaning their pH is 7.35 or lower, and their PaCO2 is climbing, BiPAP is absolutely the preferred modality, much better than CPAP or just standard oxygen in this scenario.
Okay, let's dig into the why. Why wouldn't CPAP work for that patient with high CO2? And what exactly is BiPAP doing physiologically to fix the problem?
Well, in a severe COPD exacerbation, these patients often have significant air trapping, what we call dynamic hyperinflation or auto PEEP. It makes it incredibly hard for them to even start the next breath.
They're fighting against trapped air.
Exactly. And their respiratory muscles are already working overtime. They're fatigued. CPAP doesn't help overcome that ventilatory failure because it's just that single pressure, can't really boost their tidal volume enough. BiPAP, though, hits multiple targets. First, that EPAP level helps to counterbalance the auto PEEP, making it a bit easier for the patient to trigger a breath.
Okay, helps with triggering.
But the really crucial part is the high IPAP. That provides significant pressure support, acting almost like a temporary ventilator assist. This support rapidly takes the load off those exhausted respiratory muscles, increases their overall minute ventilation, and that leads directly to faster, more reliable correction of the acidosis, the low pH, and helps clear out that excess PaCO2.
And the evidence supports this strongly. Reduced intubation.
Overwhelmingly. Large trials consistently show BiPAP significantly reduces the need for mechanical ventilation for intubation and actually decreases mortality in this specific group, hypercapnic COPD exacerbations.
Okay, so it's urgent. We need to start BiPAP and titrate it effectively. If we start BiPAP for an acidotic COPD patient, what are the typical starting settings? And how aggressive do we need to be with titration to avoid, say, undertreating them?
We usually start somewhat cautiously. Maybe an IPAP around 12 to 16 centimeters of water, and an EPAP around 4 to 6. But the key word here is aggressive titration. You have to adjust based on how the patient responds, both clinically and on their blood gas.
How quickly do you titrate?
You should be titrating that IPAP upwards, maybe by 1 to 2 centimeters of water increments, potentially every few minutes initially. You're watching for clinical signs. You want to see their respiratory rate come down ideally below 25 breaths per minute. You want to see less use of those accessory neck muscles.
And the blood gas.
That's the objective measure. You need that arterial blood gas usually around 30 minutes after starting. You're looking for improvement in the pH and a drop in the PaCO2. That tells you if your settings are working.
You mentioned something earlier, maybe in the outline, about high-intensity NPCV. What kind of pressures are we talking about there?
Right. We often need to push the IPAP much higher than that initial 12 or 16. It's not uncommon to need IPAP settings in the range of 20. Even up to 30 centimeters of water.
30, wow.
Yeah, provided the patient can tolerate the mask interface and you can maintain a good seal without excessive leaks. Recent evidence actually supports this more aggressive high-intensity approach. The reason is that lower IPAP settings often just don't provide enough of a boost in tidal volume to effectively clear the CO2 in severe hypercapnia.
So under-titrating is a major pitfall.
It really is. If you prioritize comfort over actually achieving adequate ventilation, you risk delaying the correction of their acidosis, and that just increases the chance they'll eventually fail BiPAP and need intubation anyway. We really need to use the maximum pressure they can tolerate to clear that CO2 and give their muscles a break.
Okay, that's clear for COPD with hypercapnia. Let's switch gears now to a different mechanism of respiratory failure. Acute cardiogenic pulmonary edema, ACPD, Flash pulmonary edema. Here, it's mostly hypoxemia from fluid overload, right?
Exactly. Different physiology, so potentially different approach.
Okay.
In ACPE, both CPAP and BiPAP have been shown to be better than just using standard oxygen therapy alone.
Those are better.
Yes, but CPAP is often considered the first-line choice, especially if the patient is mainly hypoxemic and isn't significantly hypercapnic or obviously tiring out yet. It's simpler.
Why is CPAP, just that constant pressure, so effective when the problem is the heart and fluid backing up?
The benefit of positive pressure in ACPE is really twofold, and it's largely mechanical. First, that constant pressure helps pop open those fluid-filled, collapsed alveoli. It pushes some of that fluid back out of the air spaces, which rapidly improves the severe hypoxemia.
Okay, clears the lungs.
Second, and this is really key, the positive pressure inside the chest has a major effect on hemodynamics, on the heart. By increasing the pressure in the chest, it reduces the amount of blood returning to the right side of the heart that decreases preload.
Reduces preload.
And at the same time, it reduces the pressure the left ventricle has to pump against that decreases afterload.
Decreases afterload too.
Right, so you get this simultaneous reduction in both preload and afterload. This helps the struggling heart function better, improves stroke volume, and ultimately relieves that pulmonary congestion. CPAP achieves these beneficial mechanical effects quite simply and effectively.
So for ACPE, if the patient is very hypoxic but their CO2 isn't high yet, CPAP at maybe 8 to 12 centimeters of water is often preferred. Simple, effective hemodynamically. But what if they are both hypoxic and hypercapnic in ACPE? We're clearly working hard to breathe. Should we lean towards BiPAP then?
That's generally the pragmatic approach, yes. If there's coexisting hypercapnia or if the patient looks like they're fatiguing, their respiratory muscles are tiring out, then adding that ventilatory support with BiPAP makes sense. In that case, you might start with settings like an IPAP of 12 and an EPAP of 6, for example.
But for many ACPE cases, CPAP alone might be enough.
Correct. Studies show CPAP is very effective for ACPE. The extra complexity of BiPAP might not add significant benefit unless there's clear evidence of that ventilatory failure component marked by the hypercapnia.
All right, now let's tackle what you called the highest risk group, where non-invasive ventilation often struggles. That's de novo hypoxemic respiratory failure, severe pneumonia, ARDS, where there is an underlying COPD. What's the main caution here?
The caution level is extremely high, and it's based on data showing really high failure rates for NIPPV in this group, and worse outcomes if intubation gets delayed.
High failure rates?
Yes, face mask NIPPV often fails in more than 50% of patients with de novo hypoxemia. Part of the reason is the underlying lung injury itself is often just too severe, requiring very high levels of support that NITPV can't reliably deliver.
So what's preferred instead?
The current thinking, based on evidence, often favors using high-flow nasal cannula, HFNC, as the first-line approach here.
Why HFNC?
HFNC tends to be better tolerated. It provides good oxygenation, some modest positive pressure, and importantly, it might reduce the risk for the patient taking these really deep, forceful breaths against a tight mask, which could potentially worsen lung injury, something called patient self-inflicted lung injury, or PSILI.
But if we do decide to try NIPPV in a very carefully selected patient, maybe they're stable, awake, cooperative, which mode?
You have to be incredibly selective. If you try NIPPV, the tendency is generally towards CPAP.
CPAP again.
Yes, maybe using 8 to 12 centimeters of water, focusing purely on improving oxygenation and recruiting alveoli. We usually try to avoid BiPAP unless there's absolutely undeniable evidence of very high work of breathing or impending muscle fatigue.
Why avoid BiPAP here?
Because those higher inspiratory pressures from BiPAP carry a greater theoretical risk of causing barotrauma or volutrauma in lungs that are already injured and stiff, like ARDS. The main strategy, if you use NITPV here, is to view it as a very short trial, maybe 30 to 60 minutes, not as a definitive therapy.
You mentioned the harm of delaying intubation. What actually happens during a failed NIPPV trial in ARDS that makes things worse?
This is such a critical concept, underpinning why that 30-60-minute reassessment is non-negotiable. When a patient with severe hypoxemia is struggling on NIPPV, maybe fighting the mask or breathing asynchronously, they can generate huge negative pressures inside their chest, trying to pull air in.
Big negative pressures.
Yes, and these large pressure swings can actually injure the lung further. That's the self-inflicted lung injury, PSLI we mentioned. At the same time, if the NIPPV settings aren't right, or if there are leaks, the positive pressure itself might be delivered unevenly, potentially causing overdistension in some areas and collapse in others, worsening barotrauma and volutrauma.
So delaying intubation lets this injury continue.
Exactly. You're allowing this cycle of lung injury to persist, using up the patient's precious physiological reserve. It makes the eventual intubation harder and riskier, and it's associated with higher mortality. That's why the reevaluation window has to be strict. Fail fast. Intubate early if needed.
Okay, that's a very important caution. Let's shift to another complex scenario. Acute on chronic OSA, or patients with obesity hypoventilation syndrome, OHS. How does having that chronic hypercapnia background affect the choice?
It depends. If someone comes in with what seems like a pure OSA exacerbation, maybe they missed their CPAP or took a sedating drug, then starting with CPAP to splint the airway open is still the reasonable first step.
But OHS is different.
OHS is fundamentally different. It's a chronic state of ventilatory failure. These are typically patients with severe obesity, and they have persistent high CO2 levels even during the daytime. Their respiratory system mechanics are altered due to the weight on their chest wall.
So CPAP might not be enough.
Right. CPAP might deal with the obstructive sleep apnea part, the upper airway collapse during sleep. But if that patient presents acutely ill, or if you know their baseline PaCO2 is chronically high, CPAP alone often isn't sufficient. They need ventilatory support.
Which means BiPAP.
Which means BiPAP is usually necessary. You need that pressure support, that delta P from BiPAP, to help augment their ventilation, overcome the restrictive chest wall physiology, and effectively lower that chronic CO2 level. BiPAP addresses both the obstruction and the underlying hypoventilation.
Okay, that makes sense. Let's switch gears now to safety, absolutely critical for both CPAP and BiPAP. We need clear lines. What are the absolute contraindications, situations where you just cannot use positive pressure ventilation?
These are really non-negotiables and mostly relate to airway protection and stability. First, inability to protect the airway. This means significantly altered mental status, severe encephalopathy, or if the patient physically cannot clear their own secretions. The risk of aspiration is just too high.
Makes sense. What else?
Second, severe hemodynamic instability or shock. An IPPV can drop preload and worsen blood pressure, especially initially. These patients need immediate airway control, often intubation and resuscitation first.
Okay. Airway protection, hemodynamics.
Third, anything making the mask interface itself unsafe. Think severe facial trauma, burns, or recent surgery on the upper airway or esophagus where the mask pressure could cause harm.
Right.
Fourth, active vomiting or a very high risk of vomiting again, aspiration risk. And finally, an untreated pneumothorax. Positive pressure could turn a simple pneumothorax into a life-threatening tension pneumothorax.
Okay, those are definite stop signs. What about situations where it's not an absolute no, but more of a proceed with extreme caution? The relative contraindications.
Relative contraindications are situations where the risk of failure is known to be higher, or where specific complications are more likely. This includes patients with very severe hypoxemia, say a aerophagia ratio consistently below 150 or diagnosed ARDS. We know NIPPV is less likely to work.
Okay, severe hypoxemia is a caution.
Altered mental status, even if not severe enough to be absolute, requires very close watching. They might not tolerate the mask or cooperate. Also, patients with excessive thick secretions or very weak cough, they're at higher risk of plugging up an aspiration.
Any surgical considerations?
Yes. Caution after recent GI surgery or if the patient has an active ileus. There's a risk of swallowing air, causing gastric distension, which can impede breathing and increase aspiration risk. And then there are practical issues. If you just can't get a good mask fit despite trying different interfaces, the therapy won't be effective. And lastly, patients with known severe bullous lung disease might be at higher risk for barotrauma or pneumothorax from the positive pressure.
Given all these risks and the need to potentially intubate quickly if it fails, the location where NIPPV is used becomes a safety factor itself.
Absolutely critical. The need for rapid escalation dictates the setting. Any patient receiving CPAP or BiPAP for acute respiratory failure must be in a monitored setting.
Meaning ICU or step-down?
Exactly, an ICU or a high-acuity step-down unit. And it needs to be staffed by nurses and respiratory therapists who are experienced with NIPPV, who know how to manage the interfaces, troubleshoot problems, and crucially recognize the signs of failure early and act on them.
So using NIPPV for acute failure on a standard medical floor is generally not appropriate?
Generally, no. It's not considered safe practice for managing acute respiratory failure due to the monitoring requirements and the need for immediate backup if the patient deteriorates.
Okay, let's get practical now. We've decided on CPAP or BiPAP, checked for contraindications. What's the step-by-step process for actually starting it, the inpatient protocol?
You need a careful pre-flight check, essentially. First, double confirm the indication and make sure there are no absolute contraindications. Then, assess the patient again. Are they alert enough? Can they protect their airway? Can they cooperate, at least initially? Patient selection is key.
And the equipment.
Right. Selecting the right interface is important. Nasal mask, or oroNasal mask covering mouth and nose, sometimes even a helmet interface, though less common initially. The goal is to get a good seal comfortable, but tight enough to minimize leaks. A leak over, say, 30 liters per minute can really compromise how effective the therapy is.
Okay, let's quickly recap those initial settings again. For hypercapnia, like in COPD, we start BiPAP, IPAP 1216, EPAP 45. How fast should we really expect to see improvement in the CO2 and pH?
You should see some initial clinical improvement, maybe respiratory rate slowing, less distress hopefully within the first 30 minutes. The goal during that initial titration phase is to find settings that deliver adequate tidal volumes, ideally around 6 to 8 milliliters per kilogram of their predicted body weight without causing huge leaks. So you're nudging the IPAP up, maybe 1 to 2 centimeters of water every 5 minutes or so, watching their work of breathing until things look better, or you reach that target ICAP needed for aggressive CO2 clearance, maybe in that higher range we discussed.
And the proof is in the pudding, the ABG at 30 minutes.
Exactly. That 30-minute arterial blood gas is crucial. You're looking for objective evidence, at least some improvement in the pH, maybe a rise of 0.02 or more, and a definite decrease in the PaCO2. That tells you you're on the right track.
And for ACPE, starting CPAP at 8-12 centimeters of water, what's the main titration goal there?
For ACPE, it's more about rapid symptom relief and oxygenation. You titrate the CPAP pressure upwards, maybe in 2-centimeter water increments. You're looking for clinical signs.
Right.
Is the patient less breathless? Is their SPI Euros improving? Is their respiratory rate coming down? Usually you don't need to go much higher than 12 to 15 centimeters of water to get the hemodynamic and oxygenation benefits needed in ACPE.
That 30 to 60-minute window keeps coming up. What's the absolute must-do monitoring during that critical initial period, especially regarding that ABG?
It requires continuous close observation right at the start. You're watching respiratory rate constantly, oxygen saturation, mental status, are they getting more drowsy or agitated? And really importantly, how are they interacting with the machine? Patient-device synchrony. Are they breathing with it or fighting against it? Is the mask leaking excessively?
And the ABG is non-negotiable.
Non-negotiable at 30 minutes. It gives you the hard data on their gas exchange. If that blood gas shows the acidosis is the same or worse, or their aerophagia isn't improving despite your efforts, you are right at the point of failure.
Let's be really explicit about those failure criteria. What defines failure that means you must move to intubation, knowing that waiting too long is dangerous?
Failure is essentially defined by not getting better quickly or actively getting worse. So first, lack of improvement or worsening gas exchange. That means persistent acidosis, maybe a pH still below 7.25, or a PaO-FiO ratio that stays stubbornly low, like under 150 to 200, even with maximal NIPPV settings.
Okay, gas exchange failure. What else?
Second, clinical deterioration. Their work of breathing is increasing, not decreasing. They remain tachypneic, maybe breathing over 30 times a minute. They're still using accessory muscles heavily.
Got it.
And third, any deterioration in their overall status. Worsening mental status is a huge red flag. New onset hemodynamic instability, blood pressure dropping, heart rate climbing, or developing new arrhythmias.
If those criteria are met, it's time to intubate.
Absolutely. The NIPPV trial's over. Intubation should proceed promptly. Delaying at this point only risks further harm from ongoing lung injury or physiological collapse.
Okay, moving into the operational side, hospital logistics. Successful NIPPV really depends on teamwork, that interdisciplinary approach. What specific safety checks do nursing and respiratory therapy absolutely need to perform?
That initial phase is all about vigilance. Nursing and RT staff need to be checking vital signs, heart rate, BP, respiratory rate, SPO very frequently at first, maybe every 15 minutes for the first hour, then relaxing slightly to every 30-60 minutes while the patient is still unstable. But it's more than just vitals. They need to be assessing the mask leak. Is it acceptable, ideally under that 30 LN threshold? Checking the skin where the mask touches any redness or breakdown starting, and constantly assessing that patient-device synchrony. Are they comfortable, tolerating it?
These frequent checks catch problems early.
Exactly. They ensure the therapy is actually working effectively, and they help catch potential complications like worsening respiratory status, barotrauma, or even aspiration before they become catastrophic.
Skin breakdown seems like a really common issue, especially if someone needs NIPPV for a day or more. What are the specific protocols for protecting the skin?
It's often overlooked, but so important for tolerance and continued use, especially since these trials can sometimes last over 24, even 48 hours. You have to be proactive. Good protocols mandate applying protective barrier dressings, things like hydrocolloid dressings or specialized foam dressings placed on high-pressure areas before breakdown occurs.
Where specifically?
The bridge of the nose is the classic spot, but also cheekbones, sometimes the forehead, depending on the mask type. And beyond dressings, it's about frequent small adjustments to the mask fit, and if possible and clinically appropriate, rotating the type of interface, maybe switching from the nasal mask to nasal pillows for a period, if tolerated, just to relieve pressure on specific spots. Good humidification also helps keep the skin and mucosa healthy.
Okay. Another really important operational point, especially now, aerosol risk. CPAP and BiPAP are known aerosol-generating procedures. How do we manage that risk for staff safety?
Yes, that's a critical consideration. Both modes generate aerosols, but BiPAP is generally considered higher risk because of the fluctuating pressures and potentially higher leak volumes.
So what are the safeguards?
Mitigation requires strict adherence to protocols. First, always use a viral filter on the exhalation port of the circuit. This helps scrub out infectious particles before they get into the room air. Second, achieving and maintaining a really tight mask seal is paramount. Leaks around the mask are the main way aerosols escape.
And PPE for staff.
Absolutely essential. Staff involved in initiating an IPPV, making adjustments, or any procedure where the mask might be briefly removed, like suctioning, must wear appropriate PPE. That means, at minimum, an N95 respirator, eye protection, gown, and gloves during these high-risk moments.
Okay, we've laid out the protocols, the safety checks. Let's circle back and really focus on the common mistakes, the pitfalls clinicians might encounter, starting again with COPD.
Probably the single most dangerous pitfall in COPD is chasing the oxygen saturation number while ignoring the ventilation problem.
Meaning just putting them on oxygen.
Right. Giving high concentrations of supplemental oxygen hi-fi euro to a patient with an acidotic COPD exacerbation without providing ventilatory support like BiPAP can be disastrous. It can blunt their hypoxic respiratory drive, leading to worsening hypercapnia and potentially respiratory arrest. For acidotic COPD, BiPAP isn't optional. It's mandatory to fix the underlying ventilatory failure. Oxygen alone is not enough and can be harmful.
And for that de novo hypoxemia group, the pneumonia ARDS patients, the pitfall is that futile trial again.
It bears repeating because it happens. Failing to recognize failure quickly and delaying intubation. If that patient with severe pneumonia or early ARDS isn't showing clear objective improvement clinically and on their blood gas within that tight 30-60 minute time frame, the NIPPV trial needs to stop.
Don't keep pushing it.
Don't keep pushing it. Clinicians sometimes hesitate, maybe hoping for a turnaround, but the data suggests prolonged ineffective NIPPV in this setting leads to worse outcomes, likely due to that ongoing lung injury we discussed. Having clear stopping rules before you even start is the best way to avoid this trap.
You also mentioned under-titration in hypercapnia as a pitfall. It seems like people might be afraid of the high pressures.
I think that's exactly it. It's often driven by concerns about patient comfort or tolerance. But using IPAP settings that are too low, maybe sticking at 12 or 14 centimeters of water when the patient really needs 20 or 25, simply won't provide enough ventilatory support. It won't adequately rest the respiratory muscles or generate enough tidal volume to clear the CO2 effectively in severe exacerbations. You have to be willing to titrate that IPAP aggressively, guided by the ABG response, up to the maximum the patient can tolerate to actually fix the problem. Comfort is important, but correcting life-threatening acidosis has to be the priority.
Okay. Let's touch on a couple of special populations. How does NIPPV fit into palliative care, specifically for patients who are DNR-DNI?
Here, the goal shifts entirely. It's not about curative treatment or prolonging life indefinitely. It's about comfort and symptom relief. For a patient with a DNR-DNI order who is suffering from severe shortness of breath, maybe from end-stage COPD, heart failure, or cancer, CPAP or BiPAP can sometimes be used very effectively as a palliative measure.
Just for dyspnea relief?
Primarily for dyspnea relief, yes. It can reduce that sensation of air hunger and decrease the work of breathing, sometimes providing more comfort than just opioids or anxiolytics alone. The absolute key here, though, is crystal clear communication and documentation. It must be explicitly documented that the NIPPV is being used solely for palliation of symptoms in alignment with the patient's established goals of care, and not as an attempt to reverse the underlying disease or prevent an expected death.
That clarity is crucial. What about postoperative patients? When might they benefit from CPAP or BiPAP?
Post-op is another important area. Patients are often at risk for respiratory complications after surgery, especially certain groups. Like patients with known OSA are at high risk. Also, those who've had major upper abdominal or thoracic surgery where pain limits deep breathing. And anyone who receives significant opioids or anesthesia, which can suppress respiratory drive. In these situations, CPAP or BiPAP can be very helpful prophylactically or therapeutically. CPAP is often used to prevent or treat atelectasis and hypoxemia by keeping alveoli open. BiPAP might be needed if there's significant hypoventilation or CO2 retention postoperatively.
Any specific cautions in the post-op setting?
The main challenges are often mask tolerance, especially if the patient has pain near where the mask or straps sit, like after facial or neck surgery. And skin breakdown is still a concern, particularly if NIPPV is needed for more than a few hours. Very close monitoring of the surgical site and skin integrity is essential.
And one last specific group, let's just revisit obesity hypoventilation syndrome, OHS, often seen with OSA, the key differentiator for modality choice.
The key is persistent hypercapnia and the underlying ventilatory mechanics in OHS. While CPAP might be sufficient to treat the obstructive sleep apnea component that often coexists, it usually doesn't provide enough support to overcome the chronic hypoventilation that defines OHS. These patients have increased work of breathing due to their body habitus and altered respiratory drive.
So BiPAP is usually needed.
Yes, BiPAP is typically required to provide that necessary pressure, support the delta P to consistently augment their ventilation, effectively lower their chronic CO2 levels, and manage both the acute exacerbation and their long-term respiratory stability.
Okay, we've covered a tremendous amount of ground, digging into the mechanisms, the evidence for specific conditions, the safety protocols, the pitfalls. To really boil it down for you, the listener, what's the quickest mental shortcut for deciding between CPAP and BiPAP in an acute setting?
Think about the primary problem you're trying to fix. If the main issue is severe hypoxemia, needing better oxygenation, alveolar recruitment, or maybe the hemodynamic benefits like in heart failure, you generally start with CPAP. Think ACPE, maybe uncomplicated OSA causing hypoxemia.
Okay, CPAP for oxygenation, recruitment, thermodynamics.
Right. But if the primary problem is ventilatory failure, meaning high CO2, acidosis, needing to rest, fatigued respiratory muscles, then you need BiPAP. Think acidotic COPD exacerbations or OHS with hypercapnia. BiPAP is for ventilation and CO2 removal.
And that huge red flag for de novo hypoxemia.
Extreme caution. Lean towards high-flow nasal cannula first, if possible. If you do trial NIPPV, make it CPAP primarily for oxygenation. Set that strict 30-60-minute deadline for objective improvement and be ready to intubate immediately if they fail. Don't let a futile trial drag on. The risk is too high.
That really provides a clear, evidence-based roadmap for making these critical decisions right at the bedside. Now, for a final thought to leave you with, we've spent a lot of time talking about how crucial meticulous setup and management are for success in the hospital. Things like careful patient education, getting the mask fit just right, aggressive troubleshooting of leaks or discomfort. How can we take all that expertise, all that evidence we've developed for making NIPPV work in the acute inpatient setting, and translate it better to the outpatient world to improve long-term adherence for chronic users? Because we know adherence at home can be a huge challenge.
That's a fantastic point, and really, it's a critical gap. The very same factors that determine success or failure in those first few hours or days in the hospital, optimizing the interface fit, ensuring comfort, providing immediate feedback and support, those are often the exact same reasons people fail long-term therapy at home. If we could standardize that high-quality initial setup, education, and troubleshooting process, maybe even starting it more formally before discharge, perhaps we could create a much more positive and effective initial experience. That positive foundation could potentially make a huge difference in improving those often disappointing long-term adherence rates for chronic CPAP or BiPAP users once they leave the hospital walls. It's about integrating those critical care lessons into routine chronic care.